Welcome to the deep dive. Okay, let's talk headaches. A patient walks in, head pounding. Such a common scenario, but diagnostically can be a real puzzle. So today we're essentially giving you a quick reference guide, a toolkit, really, for tackling those headache scenarios, especially the kind you'll see in clinical exams like PLAB. Our goal, to pull out the absolute must-know bits for managing these cases quickly but also thoroughly.
Exactly. And headaches are, well, they're everywhere in clinical practice, but they can be deceptively complex.
Mm.
The key thing, and this is vital, is having a structured approach. It's not just about being efficient. It's absolutely crucial for patient safety, for getting the diagnosis right. You need a system.
Right, a system. So let's unpack that, starting with the basics, the history. We use Socrates, right? That means asking, where's the pain? When did it kick off? What's it feel like? Dull, sharp, throbbing? Does it go anywhere else? Anything make it better? Or worse, like light or moving around? And of course, how bad is it? 0 to 10 scale.
And asking those questions thoroughly is so important. It stops you falling into traps, like focusing only on where the pain is and missing something serious. But beyond Socrates, never forget ICE ideas, concerns, expectations. What does the patient think is going on? What are they actually worried about? Maybe they fear the worst, like a tumor. And what do they hope you can do? Addressing their fears, their ICE, builds trust and often gets to the heart of the matter much faster than just symptom listing.
Okay, so we've got that foundation. Now, the differentials, this is where it gets interesting, doesn't it?
Yep.
How do we actually differentiate? What are the killer questions we need to ask?
Well, specific questions really guide you. For migraine, you'd ask about nausea, maybe vomiting, sensitivity to light or sound, any visual stuff beforehand, like an aura. And if you suspect a cyclic migraine, you'd ask, does it tie in with periods? Does it get better once bleeding starts? Tension type headache. That often feels different. More like a tight band, pressure. Usually comes on after stress, maybe a long day staring at a screen. Less severe than a migraine, typically.
Got it. So those are the more common ones. But what about the really urgent stuff? The red flags, the things we absolutely cannot miss.
Ah, yes, the red flags. Non-negotiable. Think subarachnoid hemorrhage. You need to ask, did this come on suddenly, like a thunderclap? Peak intensity super fast? Is this the worst headache of your entire life? That's key. For meningitis, any fever, stiff neck, a rash that can't explain, bothered by light or loud noises.
Okay, crucial questions.
And in older patients, say over 50, always think giant cell arteritis. Ask about scalp tenderness. Does it hurt to brush their hair? Jaw pain when chewing? That gets better with rest. Any recent vision changes. If you even suspect GCA, it's an emergency. Immediate steroids are needed to save their sight.
Wow, okay. High stakes there.
Definitely. And idiopathic intracranial hypertension, often in younger, overweight females, ask, does bending forward make it worse? Coughing? Any blurred or double vision?
That covers a lot of the scary stuff. Are there any surprising causes, things that might get missed if you're not thinking broadly?
Yes, a couple come to mind. Carbon monoxide poisoning. The clue. Headache gets better when they go outside. And ask if anyone else at home feels unwell. It's easily missed. And another big one. Medication overuse headache. Sounds counterintuitive, right? But using painkillers, even simple ones, more than, say, 2 or 3 times a week, can actually cause chronic daily headaches. It just highlights why you need that really thorough, open-minded history taking.
Right, look beyond the obvious. So history done, differentials considered, what's next in the actual consultation?
Then you move to a focused examination. Vitals are a must. Blood pressure, temperature, and a quick neurological exam. Check the cranial nerves, power, reflexes, coordination, fundoscopy if indicated. And a little tip for exams, if there's a mannequin, examine it. Don't just talk about it. Show you know the physical steps. Finally, and this is critical, safety netting. You have to be crystal clear. Tell the patient exactly when to come back or go straight to A&E. Things like, if the headache suddenly becomes severe and explosive, if they get confused, start vomiting uncontrollably, develop a fever, neck stiffness, or any new vision problems, be explicit.
Okay, that really emphasizes the practical steps. So wrapping this up, what's the main takeaway for someone preparing for these clinical scenarios?
I think it boils down to this. A structured approach isn't just helpful, it's essential. Know your specific screening questions for the main differentials, and always have those red flags at the front of your mind. It's not just about memorizing lists, it's about understanding why you're asking what you're asking and critically applying that knowledge. Build that framework.
Fantastic advice, a really valuable deep dive. So for everyone listening, the next time you encounter a headache case, maybe ask yourself, what's the one targeted question I can ask right now that might just unlock the diagnosis?